My name is Dr. Luke Raymond-Guillen. I am an infectious disease physician based in the United States, specifically in the Indianapolis area. And today we are going to speak a little bit about the coronavirus. So first of all, let's start talking about how COVID is spread. And I like pictures because I think pictures make it a little bit easier to understand. But here we have someone who is infected with COVID. It tends to cause respiratory symptoms. So here he is, sneezing, coughing, expelling droplets that are presumably packed full of virus. Somebody who's uninfected comes by, those droplets can land anywhere in what we call the mucous membranes. So like in the eyes, the nose, the mouth, they may be inhaled, and that's how it's contracted. Or when you have an infected patient who is again coughing or sneezing, these droplets with the virus may land on surfaces. If you then touch those surfaces and rub your mucous membranes, so your eyes, your nose, your mouth, and so on, that is how you can contract COVID. So once you have COVID, the symptoms tend to vary. Everybody seems to be a little bit different, but generally speaking, what I hear about is that patients usually develop sort of, fevers, chills, feel really tired, weak, run down. They may develop some muscle or body aches, or what we call myalgias or arthralgias. Some of them have some GI symptoms, so they may feel nauseous. Usually they have a decreased appetite, and they may also develop diarrhea. And then it's normally a couple days into the illness that they might begin to feel short of breath and develop what's usually a dry cough, so cough, you're not bringing up any mucus or phlegm, that progressively worsens over a period of time. And you tend to see in the younger population, they're the ones who tend to lose their sense of smell or taste. Some of the elderly or older patients, you don't usually see that symptom as often. And then if you're unlucky enough, that cough and that breathing difficulty may progress to the point where you require oxygen because your oxygen levels are low. And that's usually at the time that you'll see people present to the hospital when they're struggling to breathe.
So what is the oxygen level that is normal and that we should be concerned?
So generally speaking, for COVID patients, we're aiming for an oxygen level above 90%, 90. When you're dropping down into the 80s, I've seen patients as low as the 30s when they're first coming in, which is extremely low. They may be blue in the lips, struggling to breathe. That's obviously severe, but we want it above 90. So 90 is our goal.
Okay.
So generally speaking, when they're in the hospital and you put them on the oxygen, we're titrating the oxygen to get you above that 90% goal. Okay, and there's a lot going on in this diagram, but I think it's important because it's because of how COVID attacks the body and what it does sort of dictates how we treat it and drives that. So a lot of people don't know that your lungs, so here we have a left lung and a right lung, are filled up with tiny sacs of air called alveoli, and here we have a cross section of an alveolus. So it's a thin layer of cells with a capillary that's transporting blood around it, and allows for oxygen to go from the lung into the bloodstream and for carbon dioxide to come out of the blood into the lungs so that you breathe it out. And this is where COVID likes to attack, this lining of the lung. So here we have a sort of a diagram of COVID. So we have the RNA virus with a protein surrounding it, and these are the spike proteins on the outside, and they attack these cells in the lung. And what happens is that these cells are under attack and they release some substances called cytokines, which call white blood cells to sort of help it out and fight off this infection. And what it eventually does, it leads to a lot of inflammation. And how I like to think about it, and what I tell my patients who are coming in and having trouble breathing, is that when your lungs are very inflamed, how I like them to think about it is that there's a buildup of fluid. There's a buildup of fluid within the alveoli themselves, and then also a buildup of fluid between the alveolus and the capillary where your blood is flowing through. So the more fluid that you have in the lungs, the less room there is for oxygen, and that's why you feel short of breath. And so that's normally what you'll see in a mild to moderate case of COVID. There is some fluid buildup in the lungs, you're short of breath, you're having difficulty breathing, your oxygen levels are on the low side. And if that progresses over time, then the alveolus loses all function altogether because it's just, you know, packed filled with that fluid. No oxygen could go from the alveolus into the blood. No carbon dioxide can go from the blood back into the alveolus for you to breathe out. And that's really when you're in trouble. That's when you have severe COVID. And then over time, that's going to lead to scarring and damage to the lung.
Right.
Okay, and these are the different modalities of oxygen that typically we'll see in the hospital. So here we have a lady, and she's just on what we call regular nasal cannula. So this is hooked up to some sort of oxygen supply, be it a tank or, you know, a lot of hospitals, it's plugged into the walls. And so, you know, you can be from anywhere from like 0.5 liter of oxygen per minute up to, you know, from 10 to 15, but 10 is usually the max, 10 liters of oxygen per minute going through a nasal cannula. If that's not working, you may bump up to what we call an oximizer mask or an oxy mask. Really not much of a difference. This might be better for somebody who tends to breathe more through their mouth than through their nose. Similar amount of levels of oxygen. Then after that, you move on to what we call high flow nasal cannula. So generally speaking, if you're requiring more than 10 liters of oxygen per minute, you're going to get put on either this machine or this machine. So this is called a vapotherm. This is the just what we call an oxy plus or high flow nasal cannula. And you can be up to something like 50 liters of oxygen per minute. And we can also adjust the concentration of oxygen up to 100%. So basically pure oxygen coming in through your nose at, you know, up to 50 liters per minute. And if that's still not enough, then that's where this machine comes in. This is what we call non-invasive positive pressure ventilation. So basically a mask that's strapped to your face that is providing pressure as you're taking your breath in, and then also some pressure when you're breathing out to do what we call recruit more alveoli, try to open up more of those airways and those air pockets to improve your oxygen levels. And basically this one right here, this is a BiPAP machine. This is the last step before needing to be on an actual ventilator or a breathing machine. So if you're not doing well on the BiPAP, meaning that your oxygen levels are still low despite you getting 100% oxygen with pressure, and if you're tachypnic, so breathing at a very high rate, and still struggling, that's when you move to just a full-blown ventilator. So this is when we give you medications to sedate you and basically knock you out and put a breathing tube right into your windpipe and then connect you to this machine here, which is a ventilator, which does many different things. Basically, with that ventilator, we can control how many breaths you're going to take a minute, what volume of oxygen is going to be delivered with each breath, how much pressure the machine is actually pushing the oxygen through to oxygenate you, and then how much of the concentration of oxygen that's in each breath. And there are different modes of that ventilator as well, and you can get very, very technical. But intranet, this is probably the highest level of life support available. And if you're sick enough to need a ventilator, the morbidity and the mortality are quite high, even in resource-rich areas like here in the US.
So I have a question about the oxygen levels. You were saying that sometimes you can even get up to 100% pure oxygen going into the system with these machines. But I think that's not how our lungs work, right? Don't we need a mix? Because air is a mix of oxygen, nitrogen, so forth. Is that healthy? 100% oxygen?
Not, I mean, technically no, and it's not good for long periods of time. So I'll just backtrack a little bit. So yeah, so generally speaking, room air, the concentration of oxygen is 21%. And normally speaking, for each liter of oxygen you add about 2.5% oxygen to it, basically. Mm-hmm. When you're giving somebody 100% of oxygen, it is toxic technically towards the lungs, but you are doing it because the oxygen levels are so low that you have no choice. And it's not something that you plan on doing for a prolonged period of time. And generally speaking, you know, we try to wean that number over time to try to get it down. But if you're getting 100% pure oxygen and your oxygen levels are still low, then, I mean, what choice do we have?
Understood.
Yeah. Okay. So there's a ventilator, and here in the US, we have yet another level called ECMO, or extracorporeal membrane oxygenation, which is basically that you are on that ventilator, 100% oxygen, and despite that, we can't get your oxygen levels up. Some people qualify for this, where we basically take the blood out of the body, oxygenate it, so put oxygen in, and then pump it back into you. So it's basically a pulmonary or lung bypass, which is temporary, and every patient that I've seen on this is critically ill. And I've seen lots of people die on ECMO, unfortunately.
And so what state would someone have to be in suffering from COVID-19 to be put on a ventilator and this extracorporeal membrane oxygenation?
Yeah, sure. So just for the ventilator itself, there are a lot of different factors that lead to somebody being put on a ventilator. So generally speaking, if you are on, that IPAP machine, and despite that you are, struggling to breathe, so breathing rapidly, your oxygen levels are low, again, you're 100% oxygen, then they'll start talking about this ventilator. And then also, some people are not always a candidate for this BiPAP. You need to be awake, you need to be able to be interactive, and you need to be able to protect your own airway, meaning that if you were to throw up, you need to be able to actually throw up and not just, suffocate or, asphyxiate on your vomit. So you need to be awake and conversant and so on to be a candidate for BiPAP. But yeah, the ventilator is usually for the sickest of the sick. And then sometimes, honestly, you have a patient come through the door and you know that they need to be on a ventilator. They come in, their oxygen levels are profoundly low. You put them on, 100% oxygen, usually just through a mask. And despite that, oxygen levels aren't coming up. They're breathing, 40 to 50 times a minute. They're really, really struggling. Some of those people are straightforward that, you need to put them on a ventilator. But honestly, we try to avoid this because once you get them on the ventilator, depending on where they are in the illness, it can be difficult to get them off the ventilator. And then the ventilator itself, there are a lot of issues that can arise with our COVID patients. So with all that inflammation in the lungs, especially as time goes on and it gets more severe, you can end up with fibrosis and scarring of the lungs and end up with what we call stiff lungs. So that you need immense amounts of pressure from this ventilator to actually get the air into your lungs in the hopes that we can get your oxygen levels up. And sometimes it's too much pressure and you can end up with what we call barotrauma, which is where you basically pop a lung. So you end up with, a pneumothorax, or sometimes you'll see what we call mediastinal emphysema. So air is escaping within the chest. And so you'll see their face blow up, their chest blow up, their neck blow up, and you can feel the air under their skin. Yeah, it's not pleasant for anybody.
So we try not to do the ventilators as much as possible.
Yeah, it's always a last resort. We will do anything we can do to try to prevent that. And there are some things that you can do, actually. So usually what we recommend is that if you're able to do it, and you're just on, some other modality, is what we call prone, which means to lie on your chest or your stomach and try to breathe that way. And what we find is that actually improves the ventilation in the posterior parts of the lungs, and we'll see the oxygen levels actually pick up. The issue is that a lot of people who get sick, unfortunately, tend to be a little bit older. They may be overweight, and so that can actually hurt their back quite a bit. They're uncomfortable. They're not used to laying on their chest, so they can't do it for long periods of time. But when I have a patient who's struggling to breathe and I'm worried that they're going to be on the ventilator, I always tell them to lay on their chest as much and for as long as possible, in the hopes that you buy yourself some time for the inflammation to improve with the medications that we're giving to hopefully avoid having to put them on a ventilator.
So right now, how often are you seeing patients coming in with the need for oxygen and even ventilators right now?
Well, because I only see patients in the hospital, it means that I'm only seeing the COVID patients who do need oxygen. So who are coming in, you get oxygen saturation when they're coming in, and it's under that 90% threshold. So that's who I'm seeing. And usually we'll start them off just on this nasal cannula. And then you're constantly monitoring their oxygen levels and making adjustments. So as time goes on, like I said, if you're on the nasal cannula and you're passing that 10-liter threshold, then you're getting put on this machine or one of these, so the high flow nasal cannula. And then, we're giving medications at this point, trying to get the information better to try to get the breathing better. And then, if that's still not enough, then you move forward or onwards to the BiPAP machine, and then sometimes onto the ventilator. So I can't tell you like how many patients progress and get onto the ventilator, because honestly, what I'm seeing is skewed. I'm seeing the sickest of the sick.
But still, it's a lot.
Yeah, I'm seeing a lot, but I mean, simple COVIDs who just need a few liters of oxygen, I'm not seeing them. I'm going to see the sick ones, because we're going to be talking about drugs that have significant side effects that I have to discuss with the patients and sometimes with their family to talk about giving them.